So if everyone could take their seats. For the second talk, today we've got Paul Taylor. His talk is What is Dying? Let's do it.
Okay. Can everybody hear me okay? Right. Hi. So my name's Paul Taylor. I'm a palliative medicine physician based in Sheffield and a senior clinical lecturer in palliative care at the university there. Arjun reached out to me some time to contribute to this session. I thought it was really, really interesting. And what's been really nice is just coordinating, learning a bit about what Tina's already talked about. That was really fascinating talk, and Guy's session later on as well. So hopefully we've coordinated well. I think you will find that there's a lot of similarities with what we're saying, but hopefully from just slightly different angles. I'm going to talk a bit about social context first. Death and dying has become increasingly medicalised, often taking place in hospitals and care homes. And as a palliative care doctor, I find it's quite common to support people well into their 40s and 50s who haven't seen somebody die and don't know what's normal. It doesn't help that television and film often portray death and dying inaccurately. If you think of how resuscitation is portrayed in your average television medical drama, it's usually very dramatic, very successful, and 10 minutes later, the person is awake and sipping a cup of tea. And anyone who's been part of a successful resuscitation attempt will know usually they're not successful, and the person, once they've been resuscitated, is sick for a very long time afterwards. The other thing that doesn't help is other depictions of dying are often also inaccurate. If you think of sort of a classic TV depiction of somebody on their deathbed, they're lucid, they're dispensing gentle wisdom before they finally slip away. And again, that doesn't tend to be what we see in reality. If you want to see a good depiction of what maybe a more normal, realistic depiction of dying looks like on a TV program, I can recommend The Royal Family, comedy from the 90s. A depiction of how the grandmother in that dies is very, can be a difficult watch, but surprisingly realistic. This means as professionals, we have to check ourselves and relay information that to us can seem very familiar, but is actually very new and frightening. And we mustn't let what is day-to-day practice for us, we mustn't let us forget that it may be a once or twice in a lifetime experience for the families that we're looking after. There is a need to improve death literacy as a result. And three authors here I can recommend. Kate Granger sadly died as a doctor who experienced a palliative diagnosis and wrote about her experiences there in a book called The Other Side. Kath Mannix and Rachel Clark, I'm sure you've heard of, very well-known commentators on palliative and end-of-life care. So I've been asked to come today and draw a combination of my clinical and academic experience. So what do I think of when we talk about what is dying? And in addition to that, I'm kind of going to talk you through what I see. So it's going to be quite clinically focused and quite experiential as well. So I bring academic experience as a palliative care researcher, clinical experience as a palliative care physician, and a fair amount of honest uncertainty, which we will get to. What am I not going to do? I'm not going to try and get too much into the higher level interpretation of this. When Arjun rang me to talk about this, he was starting to talk about some of the ideas that have gone around, and I got quite excited and was throwing things out there. And Arjun very kindly reined me in a little and said, that's part of what we'll be discussing. That's part of the purpose of the workshop. You're going to get some of my thoughts, but I'm hopefully much more interested in sparking debate. So in the same vein, I'm not going to be giving clear-cut answers. So, academic insights. Talk a bit about what is dying and what does dying look like from this point of view. Some useful texts. I'll be repeating a little bit of what Christina's talked about. We're nothing if not up to date in palliative medicine, so we'll be starting with Hippocrates. And then I'm going to mention William Osler, who I'm sure you're familiar with. And then I'm just going to link into some of the modern guidelines that Christine has already mentioned. So why Hippocrates? Hippocrates wrote a book called Prognostics, which was translated. You can get it online, it's freely available. And he described wonderfully why prognosis is important. You'll have to forgive the slightly sexist language here, but here we go. It is impossible to make all the sick well. This indeed would have been better than to be able to foretell what is going to happen. But since men die, some even before calling the physician, from the violence of the disease, and some die immediately after calling him, having lived perhaps only one day or a little longer, and before the physician could bring his art to counteract the disease, it therefore becomes necessary to know the nature of such affections. So 2,500 years ago, recognizing the importance of being able to explain what's likely to happen, support people when predicting outcomes. William Osler, he conducted a study described here in this paper. I have careful records of about 500 deathbeds studied particularly with reference to the modes of death and the sensations of the dying. The latter alone concern us here. 90 suffered bodily pain or distress, 11 showed apprehension, 2 terror, 1 spiritual exaltation, 1 bitter remorse. The majority gave no sign one way or the other, like their birth, their death was a sleep under forgetting. 120 years ago, and when I was doing reading for my PhD, I think this was the first example of what we might look at as sort of modern medical research around dying. I can really recommend Hinahara's paper here. When I pictured William Osler, because he wrote one of the main medical textbooks, I imagine this very stern Victorian physician. He was a bit of a practical joker, but he also, there's quite an incredible description of him talking a young girl who was dying of tuberculosis around dying, and he used a rose that he picked from the garden, had a little tea party with this little girl. This man, 120 years ago, was able to tailor his communication skills to his patients, so I can heartily recommend that. And then NICE guidelines, which, again, Christina alluded to, assess for changes in signs and symptoms in the person and review any investigation results that have already been reported that may suggest the person is entering the last days of life. These include, and we'll talk through some of these if there's a bit of medical jargon, signs such as agitation, changed Stokes breathing, deterioration in level of consciousness, mottled skin, noisy respiratory secretions, progressive weight loss, and some other symptoms and signs here. So there is some sort of literature out there that brings us to helping to recognize when people may be very near the end of life. And as Christina alluded to, this is generally focused on those final days. But there's a challenge that comes from this. These recommendations, they resonate with professionals, but the research base underpinning them is limited. You don't have to dig too far to find the evidence gets quite thin. And actually that same NICE guidance lists some research recommendations. And the top one is what can multi-professional teams do to reduce the impact of uncertainty of recognizing when a person is entering the last days of life. So although there are recommendations out there, there's a need to improve that research base. As part of this, I undertook a PhD, and the title was Clinical Decision Making at the End of Life. It was a mixed methods piece of research, so quantitative and a qualitative arm. So break that down into 2 questions. What physiological changes occur in the final 2 weeks of life in end-stage cancer and heart failure? And how do medical and nursing staff recognise when a person is dying? And then a mixed method synthesis as well. And important to recognise that as a piece of research in its own right. So this, you'll be pleased to know I'm not going to talk you through all of my graphs. I view recognising dying as a form of prognostication, very short time scale. We looked at routine and collected physiological data and plotted that according to time prior to death. We looked at values and change in values occurring in those final 2 weeks and used multi-level modelling. Briefly, that's a statistical technique that models both individual values and groups of values, so you can get trajectories and map them. And I looked at the association of these values and changing these values in the time leading to death. Now, these 2 examples I've shown here, the top one is respiratory rate and the bottom one is oxygen saturation. And you'll see over time, that is on the left, so you'll see that as death approaches, respiratory function deteriorates, breathing speeds up, and oxygen levels drop. There was a lot of other things that we looked at. Kidney function tends to deteriorate as well. And that's much more noticeable in heart failure, which if you treat people with heart failure, you would know is to be expected. The drugs often put a significant strain on the kidneys. Some other things slightly unusual though. Tim earlier on mentioned using early warning scores. And in an early warning score, when people are very ill, we often see the heart rate go up and their blood pressure drop. That doesn't tend to be the case in these patient populations. There's also changes in blood tests, white counts go up and lymphocytes drop. So, and some other things changing over a longer time scale. With that in mind, there's a sense to me, which I'll come back to, that there are certain differences between what we might imagine as normal or natural dying and acute illness. And we'll come back to that as a concept. So that's the numbers, the qualitative aspect of it. How do medical and nursing staff in these specialties recognise when a person is dying? I interviewed doctors and nurses with experience of caring for cancer and heart failure patients and asked them how they know this. We used semi-structured interviews and focus groups and used Braun and Clark's method. There's a picture of a radio there because my abiding memory of this was sitting in an office with a professor of cardiology with the strains of Radio 3 playing in the background, which made transcribing the data a little more enjoyable. But I got a fascinating quote from this professor. The trajectory of heart failure in patients who have advanced disease who are slowly deteriorating is like that child's game when you try and skip a stone across a lake. The first bounce is quite a big one, and the second one is a bit smaller, and the third a bit smaller, and it goes deep, 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 and then sinks. And heart failure is a bit like that towards the end. And then another quote from a nurse talking about how they use intuition. I think a lot of it comes with the experience of being around patients. I've nursed for 33 years and I've nursed for a very long time. And I have, I don't know, a sixth sense. It'd be silly to say that, but I do kind of know when someone's dying. This nurse describing quite beautifully the concept of intuition, of knowing without knowing, but not really being able to express that. A higher level analysis of that. The recognition of dying is time dependent. Professionals often need to understand change over time. One of the participants described visibly picturing a mental graph of how things change over time. Ongoing, professionals often prefer to avoid a one-off decision, maybe plan a further assessment before committing. And iterative, professionals like opportunities to revise decisions, such as review a response to treatment. And alongside that, a strong reliance on intuition. Bringing all of that data together, highlights, and again, you'll see there's a pattern developing, trajectory of change is important, management of patients' impacts on decision-making. Decision process requires repeated iterative assessments and may benefit from an MDT approach. Uncertainty is a defining characteristic of the overall process. And objective measurable parameters, they have a role, but it's not the whole picture. So that leads us into some challenges. Many of these changes are associated with other conditions. For example, poor respiratory function in pneumonia, poor functional status in stroke, poor appetite with cancer treatment. Some changes are different than in acute illness. I mentioned heart rate and blood pressure, for example. So there's a challenge to need to identify reversible factors where appropriate without over-treating dying people. And this is just a very simple, well, it's quite sort of obvious, but I think it's a useful way to conceptualize it. It tells us that this is quite a high stakes decision. If you're looking after someone who is dying, but you're focused on looking for the reversible problems, the risk is that you'll overtreat when the priority should be comfort. And there's this concept, one chance to get it right. If somebody is dying, we want to minimize how much unnecessary medical intervention we're giving. But of course, we have to recognize that sometimes people come in unwell and they look like they're dying, and there's things that we can treat. So we need to be able to identify those patients. If we get it right, you'll have appropriate management of reversible illness and appropriate palliative care. It's an obvious diagram, I think, but it just helps us to conceptualize that it's a high stakes decision either way. So in summary, there's some measurable changes that are common as people near the end of life. There's some evidence that these changes are different to those in acute illness. Assessing change over time, response to interventions is important. Clinical staff use intuition. There's a need to be honest and open about uncertainty. And we'll come back to this, but a person's own preferences are a critical part of the decision process. So I'm going to move to talking about clinical insights here as well. When I'm teaching medical students, I'll often have a bit of a warning around this. So we'll be talking about what death and dying look like. I imagine most people here are here to hear about this, so we'll be prepared for it. Please feel free to step out if it's upsetting. I've been very academically focused up to date, so we're going to talk about clinical experience, and it's going to be more, as I say, experiential. If you want to see someone describe in a very sort of realistic and accessible term what death and dying look like, Kath Mannix I can recommend. This is her website, and she talks about this, and there's a video that's on the BBC website where she describes this. And I've just got some quotes from this video here. Most people are not conscious by the time they die. It doesn't feel like going to sleep, it's just a state of non-awareness. To begin with, dying people might only be unconscious some of the time. In between, they may wake up and talk, or sip drinks, or listen to the people around them chatting. They may become a bit muddled or restless. It helps when people hold their hand and talk in soothing, gentle tones. Familiar, trusted voices calm and comfort. Unconscious people breathe in an unusual way. Their breathing pattern gradually changes backwards and forwards between deep and shallow, between fast and slower breaths. This is normal. Sometimes the breath gurgles or rattles. It's not uncomfortable, it's completely normal. And this idea that hearing is the last sense to go. That's why loved ones and caregivers can keep talking, and some people make end-of-life plans. So what's Kath describing here? She's talking through, in very sort of accessible terms, a number of things that we observe as professionals. One of the things, we saw Christina's trajectory graphs earlier on, and one of the things that we talk about is functional status. Measure a person's ability to self-care and undertake normal activities tends to steadily deteriorate with time, moving from needing help to being increasingly reliant on nursing support to being nursed in bed. We have the concept of trajectories. We have examples like specific needs, such as incontinence. Oral intake changes. People often require much less food. When we're supporting people who are nearing the end of life, this is an important thing to help discuss with patients and families. It can be a source of tension. Similarly, people often require less fluid. There's currently a big study being undertaken to try and work out the role of fluids in people near the end of life. Oral medication intake often lessens. Sometimes we'll stop medication that isn't helping. Sometimes we find a better way of giving it. Awareness changes. You'll pick that up from the quotes from Kath Mannix. If people increasingly feel sleepy, will often spend less time awake, and usually towards the very end of life are deeply unaware. There's a received wisdom, particularly with some hearing, that people retain a level of awareness for a little bit longer than expected. But again, evidence behind that is thin. People can develop a delirium that can lead to agitation, and it's often important to look for causes of this. So that's one of the things that might just prompt us to do some additional investigations to see if we can treat the cause. It's also quite important to explain to families that this is quite a common observation. Sometimes they can try and attribute meaning. I had a relative come to me who'd seen somebody die many years ago, who's convinced they were trying to tell them something and hadn't realised that quite a lot of people near the end of life can just can become restless as part of that process. Breathing changes. So this is a phrase, Cheyne Stokes, that you will have seen in the guidance I mentioned earlier on. Particular pattern of breathing very near the end of life. Where breathing speeds up and slows down. Respiratory secretions, sounds like somebody needs to cough and clear their throat. Agonal breathing, that describes respiratory movements, but without a lot of air moving, tends to be in the very final moments of life. But we have to note as well that pneumonia and respiratory infections are very common in dying people. Skin changes. Skin can become cooler and pale. Sometimes family will say skin looks white or yellow. Very near the end of life, it can become quite mottled with sort of dusky red or purple patches. Pressure damage is a high risk. Prevention remains important, even in the final hours. So you'll see that good nursing care at the end of life still involve very attentive pressure care. Skin can be quite dry, prone to itching. It can have fluid underneath it, edema. It can bruise easily. So good skin care is something that the nursing staff take very seriously. So in summary, sort of from this clinical experience, these signs such as agitation, breathing patterns, we'll see symptoms such as increasing fatigue and loss of appetite, and these functional changes as well. So I'm going to just highlight some challenges from a clinical point of view as well. I'm conscious while I'm talking, and it's really helpful to have intensivists in the room because this is a very palliative care approach. And even as we're talking about the philosophy of what is dying and recognizing dying, I'm talking from a very specific experience of working in palliative care, where often we recognize that people are nearing the end of life quite early on in that journey. But what are our challenges? Well, similar to the academic observations, some of these things have alternative explanations. Breathing changes can occur when you get an infection that might be treatable. Oral intake can change with intercurrent illness. Skin changes can occur with sepsis. Lots of things can cause delirium and reduced awareness. Now, I have to say that the pattern is often different in dying people, tends to be part of a bigger picture. But I think we have to recognise that as part of how we approach people nearing the end of life. It's not that there's this simple tick box series of symptoms that we can identify and make a clear-cut diagnosis. Which leads me to sort of highlight some of the reflections I said I was going to bring. And I've kind of broken it down. There's this concept of soul midwives, people that support people nearing the end of life. And then we talked earlier on about death as an accumulation of events. Do we view dying as a final event resulting from an accumulation of physiological insult, a natural predictable process akin to giving birth? My reflection here is that neither of these approaches tells a full story, and an uncritical assumption of either approach risks errors. And there's also an important thing to think about the role of treatments. Often decisions about treatments are not clear-cut. For example, pneumonia is quite common in people nearing the end of life. Well, antibiotics help. They help symptoms. Some treatments do help with symptoms, and they do also prolong life. So oxygen or diuretic medication in heart failure. When does a situation transition from aiming to preserve and save life to recognizing and managing dying? And this is reflected if you dig deeper into those comments from NICE guidance. I won't read them all out, but it is reflected here that the role of response to treatment, the ability to reassess, come back, revise your decision are all important. And that therefore brings us back to this idea of this high stakes decision and needing to know where our priorities lie. And the final thing that you're probably hoping I'll get to, which is critical here, is preference of the patient, the person at the centre of this. It's often a critical factor, I'd say always a critical factor. The decision process here is obviously complex, exists within a legal framework of capacity, and often involves carers and families. Sometimes the medical context gives clarity to treatment approaches and how say, aggressively we might support somebody and what our focus might be, but it's often more nuanced. So we need to explore these preferences sensitively. Many people who are very near the end of life do decide to forego medical intervention that have quite limited benefit and choose that focus on comfort. Occasionally, people decline to have a procedure that could prolong their life by a longer time scale. And part of our role here is really working with the people that we look after to support their decision-making on that. Occasionally, some people are having an ongoing medical intervention that is keeping them alive and decide to discontinue that. It's not common. Examples might be dialysis. Usually, this happens as part of an ongoing bigger picture of somebody becoming more unwell. But some people, their preference is to choose to continue active medical intervention right up to the end of life. And our challenge, I think, as palliative care professionals or healthcare professionals in general, is to support the decision-making and try not to project our own worldviews around what's right and wrong. So summary now. So summary of the academic and clinical insights. Recognizing dying is difficult. It's not a one-off tick box process. There are signs that occur near the end of life. None is clear-cut. You've got to be considered in context. Expertise, time, the ability to revise decisions, and the ability to review response to treatment are all important factors. And an individual's preference regarding treatments is often an important factor, especially when you're considering what you might try. So looking ahead, what we do have is a broad framework for recognising when a person is in their final hours or days of life. But there's clearly a need to sort of enhance that research base. I think there's a need to be honest about uncertainty when supporting the people we care for. I think probably the most useful thing I took clinically from my PhD was I feel much more confident in saying I don't know, and much more comfortable in expressing that uncertainty to people. And even then, and I think this is the purpose of the day, understanding what we mean by dying is challenging. So that's the end of sort of my talk to you. I realise the purpose of today's discussion, so I thought I would very open and see any questions.
I'm looking at getting a useful about when we think about pronunciation, but I noticed that your talk a lot of the stuff about how people talk. Because certainly a difference between the way that I talk and the abstract investigating people who are doing well or recently running their application setting. So how I talk to patients who are coming unwell. And I don't know if it's my influence, their influence, but when sometimes that becomes less about awareness instead. What about how people die? And I guess that's, for me, one of the things I'm thinking about is whether is what is dying exactly right. You know, do we need to think about how people die, how does that happen, and sort of what makes that change in that sort of importance to individuals, whether if that's the importance in your own sort of clinical work, is that people are more interested in how they're going to die.
Okay.
What you would say about that influence in the question. How am I going to die?
So I'll repeat the question because I'm aware there's been comments about one. So the question there's this question about when will people die, but also to what extent that overlaps with how do people die, and to what extent that we face that question in clinical experience. Is that a fair summary? Yeah. So it's absolutely, first of all, yes. I think when somebody starts to ask questions about timescales, it sounds odd, but often the first question is sensitively asked. What do you mean by that? Why do you want to know? Because sometimes it's just the door opening question that leads to that much bigger discussion. So it's often the beginning of a gentle discussion around what to expect. Now, of course, what I've given you today is discussion of very general experience, and what a person might expect is going to be very tailored to their particular diagnosis and situation. So yes, there is a sense that question, how long have I got, is very much what should I expect. There's also a sense of walking alongside. So sometimes I'll honestly say to somebody, actually, I don't know what timescale you have, but we will be alongside you. Would you like us to be honest with you when we see changes that we think things are changing more quickly? And then some say no, most say yes. So then there is that sense of walking alongside. And the other thing is sometimes when people ask about prognosis, there is a specific time-dependent reason. They have a family wedding or something like that. And although it's often very hard to give a definite prognosis, you might be more definite about whether or not somebody will or will not see a particular life event. So if somebody who you feel has quite a poor prognosis says they've got a family member getting married next year, you might say, I'm sorry, that's less likely. But then you build on it and say, so how can we help you celebrate it? And it's that kind of iterative overlap of management and support. I think the other thing I'd say that came out of our decision making is this sense that management, support, prediction, diagnosing, they go hand in hand. We tend to like to think you make a diagnosis and then you start the treatment, and in all of these ways. That answers your question.
Rivka?
I don't know if it's happy to ask a question here. The thing about that, so the role that the patient preference was subjective values of the patient, and their role there, I'm just interested in clarifying here. So it seems like a few different decisions going on. So one is in the deciding that someone's in a state of dying, and the other is in deciding how to treat and deciding for something else.
Yeah.
And then, so my question is the implications of what you just meant to articulate about holding people's hands through the process, that actually even deciding that someone's in a state of dying is about their preferences, as opposed to just deciding whether they're being treated. And so then what dying is becomes this really subjective concept, which I can come out and how we will talk about more. It's kind of about people's values and their.
So, yeah, but I talked earlier on, so again, I'll repeat that question, the sense of the overlap of how people's preferences are important, widens the concept of what recognising dying is from a, you might have said, a purely sort of medical model to then integrating the views and preferences of that person. Is that a fair summary of the point? Just for the benefit of the people on.
I think it could be, but yeah, no, it's the definition of dying becomes a subjective definition.
Yeah. So
Process of management.
Yes. Okay. Yes, I hear what you're saying. So this overlaps a little bit with some of the things that was when I mentioned Arjun talking about some higher levels of reflections and things like that I'd wanted to bring in. And this, there are certain ways in which the medical context, I think, really defines what can and can't be done. But there are other contexts, like the example I gave of somebody declining treatment that is life-prolonging, where the person's preference is critical. So I don't think we can fully separate out that recognition of dying from the individual's preference. And part of, I think, the discussion today is around the nuance around it. Now, as a doctor, my role is often to bring into it that clinical knowledge and to try and bring down, well, this intervention might help here. Where does that fall? So.
Next, Jim. But before that, we will go online. So Emily Collins asks, as a palliative care consultant, I note many of my colleagues feeling uncomfortable when a patient expresses a wish to be drowsy, unconscious towards the end of life, while the family expressed this on their behalf in the last days of life. How comfortable do you feel with our current legal framework to meet these preferences? From your own clinical experience, do you feel that people have an ability to alter how long they will live towards end of life, i.e. living longer than they would physiologically might due to a strong will, or living shorter due to giving up?
Okay, so two questions there. So the first one, it's a tricky one, if I'm honest, and perhaps one to bring to the whole group. At the one end of the spectrum, well, there was a case I'll cite, I can't remember which hospital it was at, but somebody who had a very distressing condition, was in a lot of pain, but was actually not near the end of life, asked to just be deeply sedated and then not given food and fluid. And the doctors in that weren't happy to do that. It went to, I think it was challenged in the court, but the medical decision was upheld. So that's the one extreme. It is a challenging one. I think one of the common situations we face is when we're trying to deal with a challenging symptom and we recognise that the medication to treat that symptom will have some side effects that will increase risks of things like sedation, drowsiness. And that's often a conversation we will have with patients and work out what their preferences are. There are some people who will accept quite significant elements of sort of ongoing symptoms in order to retain their alertness as much as possible. Some people will prefer the symptom to be robustly controlled. The other thing I would add here is that reduced conscious level drowsiness, they are common in people who are dying, whatever we do with the medication. And there's a sense sometimes that we think that it's just the medication that contributes to this. It's not uncommon in palliative care that I'll be supporting someone who is dying, who's unresponsive, very sleepy, and actually doesn't have a great deal or even any sedating medication. So I think we have to recognise that as well. The second question, I think there is a sense that we've all looked after people who we think hold out for a certain event. And yeah, and they'll hold out, particularly if there's something that's been really important to them. So I think there is some evidence behind that. I'm sounding a little bit hesitant because occasionally there's a sense that people might think their relative has died because they've quote unquote given up and suddenly accepted a lot of care or a hospice admission or something. I think there's a possible reversal of cause there, that actually somebody just reaches a point where the symptoms are significant enough where they're near the end of life, and that's when they accept that help. But certainly coming back to that specific question from Emily, I think yes, that is the received wisdom, and I think anyone who works in palliative care will have memories of cases where that was. Yeah, I would say.
Thank you very much for this talk. And so, therefore, Robert, you seem to make quite a clear distinction between acute physiological decline or illness and dying, or whether that's whether you need to.
So,
do you look on them as separate, or is the dying parameter short from that? Is that not just a version of physiological?
It is a question I wanted to spark in this. I think so that's where I came back to this idea of sort of final straws and soul midwives. I think I would say that there are some evidence that sort of dying from a condition like cancer, heart failure, the physiological sort of changes that we see are not entirely the same as those that we might see in acute illness. But I think where that distinction lies, I couldn't give you a definite answer. I kind of wanted to throw out there for the purpose of discussion and as a topic for research that I think there may be some difference, but I don't know where.
Some of the points towards the end of the house will go to the points that I get on stage, but say this which kind of brings up the end. We talk a little bit about any practice, people uncertainty, whether actually it's not really kind of what it's about it. So it's like it. I'm going to start you to learn from there, like the moment that artificially creating a scene for the best, more or less certainly to the bottom of the brain. Just kind of wonder how, when you think about what your biggest care consultant, how you think about it aiming at what we're trying to do, and also it's more than just kind of, now how do you know that you're going to control?
Yeah.
We're not just believing.
Okay. Yes. Thank you. So I'll summarise that again. So bringing back this idea of the balance of a person's preferences versus medical intervention, summarised, I think, very nicely on how do we know when we're doing a good job. I've slightly fallen foul of one of the things I try and teach our junior doctors to avoid, really, which is this idea that there's a distinction between good comfort care and treating potentially reversible factors. Actually, a lot of the treatments that might help treat something theoretically reversible are not hugely burdensome. And if your patient's happy enough to have them, then they can run alongside. Likewise, the drugs that we use to treat symptoms like pain, opiates managed carefully are quite safe to be running alongside sort of these active medical treatments. So treating reversible problems and managing symptoms can more often than not run in parallel. How do we know when we're doing a good job? I think it's incumbent on us as palliative medicine physicians to bring the medicine to bear on this situation and to understand, keep ourselves abreast of what might help, to understand where interventions may have a role and may not. I spend a lot of my time speaking to professionals in other specialties, really helping to understand that. I would think I've done a good job if I feel I got alongside the patient and supporting, made sure that they've had the best sort of knowledge, the best information available to help support them, and yeah, bring them through that journey the way they want. I've looked after somebody who were very keen to have as active intervention as possible, and 5 years on, you know, through the acute illness that we brought them through, still their wish. And I feel like given that person the palliative care, and some people who have said, you know, I've had treatment for this condition, it's helped, but now I'm really at the stage where I don't even want the drip, I don't even want blood tests, I just want quiet time with my family. And provided I'm happy that you know, that we've supported them in that decision process, then the care we give to them, I would regard as. That helps.
Inherent questions, you think that some there can be things too much, like where we have too much control, you know, perhaps resolving in big, there's some things we're actually having full control about every single element.
Yes, of course. So this concept that we could have too much control, I'm slightly self-deprecating. I'm a bit of a control freak in the way I work, and what's really important there for me is that I listen to my colleagues from the wider team, particularly the nursing staff, and particularly the whole team really. One case that really stuck in my mind was a healthcare assistant, the kind of healthcare assistant that would never speak to the consultant, came to me quite upset and said, I think you've missed something here. And I've never been so quick to go back and reassess what I was doing in the situation as I was then. So there is that sense of, yes, perhaps overestimating the control we have.
Well, I mean, all the giving the patients, going back to the bit where I'm stage.
Okay. Yeah. Okay.
It's not so good control, it's more about something about it keeping up than.
And then sorry, I'll come to you in a second. And then to get a little bit meta about that, to what extent do you want to be involved in these decision making, in these decisions? Because you will also know those patients that say, you're the doctor, you just make the decisions. And then I will say to them, okay, but at these points, I'm still going to need to just check in. And they want to offload that decision to the decision in itself, I think. Sorry.
Can I actually, so was that in terms of as factors and illness, so would that be kind of influence or effects of consumerism in terms of purpose, and people that which
So then saying, could these decisions be influenced by consumerism?
Yeah.
So what a sense that sort of cost of care provision might be an influencing factor. Is that what you're saying?
Or people having a right to demand.
Oh, sorry. Okay. So does consumerism as a concept influence this decision making? Again, possibly an interesting one for the wider discussions later on. I am quite focused on working with the people I look after to provide the care I want. I'm not sure that that's simply outworking of consumerism. Maybe a reflection of the movement away from a sort of a more paternalistic style of medicine. But I think that's probably a conversation that could really animate the group a little bit later. Sounds like I've dodged that question a little, but yeah, I think there's more to it.
Sorry, you talk a lot about respecting the autonomy of the patient, the following up with Timothy, and it feels to, as an intensive care, we're in a very different place.
Yes.
We justice is much heavier on us.
Yeah.
And we are, you know, turning away people.
Yeah.
To one standard of care and rights in there to benefit. So we, I love to see yours down much more doing what we want.
Yeah.
But then knowledge of what is good about it, but we're in a very different, we're very different balance of sort of pillars.
Yeah.
Just on the position.
I think I'd simply say that's a very fair comment. So again, for the people dialing in, and just an observation that I've portrayed palliative care as being very focused on personal preferences, but in the intensive care unit, the medical context and resources are often quite a significant factor to weigh up. I think that's a really fair observation. I think in palliative care, the ability to make those decisions hand in hand with our patient, their preferences, is more straightforward. A hospice, by its nature, there are limits to what can be done in a hospice. We don't have X-ray machines. We can do bloods and we can give intravenous therapies, but there is often a cutoff where we can then say, actually, this treatment beyond this is beyond what can be given in the hospice. And then our role is maybe bringing in, what would you gain from a transfer to hospital? You've given me food for thought there. Is then are we that those harder decisions we're then passing along to colleagues in the acute trust, and perhaps there's responsibility on us to look more closely at those boundaries and those envelopes.
Thank you.
Probably have time for a quick, succinct point.
Max tried to consider about this idea of paying up too much choice. I can't remember who did the study, but they looked at the choice satisfaction. They gave people a painting, and then they gave half the group, they showed them another painting, gave them the option to choose, and half the group they said you have to stick, or you are automatically given. And the people who were most satisfied were the ones who didn't have choice. So you were less satisfied with whichever thing you ended up with. And so I think there might be something actually about having too much choice doesn't always improve the utility of that as well. But coming back to this, one of them came through with Christina's talk, as I thought, was, is there, are we clinically using sort of pragmatic concepts of dying? So depending on the decision we're trying to make, what we're defining as dying is changing. So we're prognosticating each side about care, we're looking at how much can we fund for a year, because that's the limitation for 12 months, isn't it? Or the 3 months for, which is like 12 months benefits, 3 months for care is. Whereas if we're maybe deciding about treatments in a hospital, we're weighing their preferences and the burdens of treatments, not it's. I mentioned about, can you get to, someone's wedding in a year's time, for example, you're making a decision of actually we're defining dying as a shorter period of time there because you're not going to take this thing that's important. So again, is it multiple concepts of dying that are just about not just the time length, but about what decision we're making in the context of them?
Okay, so the multiple concepts of dying not only influenced by time scale, but also the specific decision we're making. Yes, and again, I think that's part of the purpose of today's discussion, really. I don't think I think your question was a point as well, and I think I would agree with that that it does depend on what we're asking.
Right. Okay. So we are still on time, which is inexplicable. So we have a 20-minute coffee break, but thank you very much, Paul.